Hey, everybody, we will get started in just a second and give people time to hop on and join us. We're so glad you're here. Um, so I will start maybe around 102, 103, just to give some people some time. Okay, we have a jam-packed 30 minutes of information for you all. So we're really excited to get started and welcome in. Um, So we are here for to talk about maternal suicide. Very difficult subject. Can you go to the next slide, please, Amanda? Um, and this is a part of the Is Mom Okay campaign with Cherished Mom. I am Christina Delaney. I'm the founder of Cherished Mom and executive director. Our mission is to empower pregnant and postpartum women, their families, and perinatal healthcare providers. We are committed to raising awareness and eliminating the stigma associated with PMADS, particularly focusing on pregnancy and postpartum psychosis and the prevention of maternal suicide. So we're really honored to have this conversation today. Next slide, please. Just blanket trigger warning throughout the whole time with us here. We will be talking about suicide ideation, and we'll have a story too that we'll talk about that. Next slide, please. Again, I'm Christina Delaney. We also have Allison Palmer with us, and I will introduce her here in a minute, but I think we have our story first with Heather Martin, which I think is the next slide. Well, webinar overview first. So we're going to be recognizing the warning signs of maternal suicide, talking about screening, steps for prevention and support, and really a call to action to identify and respond to those who are at risk of maternal suicide, and share some resources as well. And I'm honored to have Heather here with us. She is going to share the story of her sister, and she's done a lot of really great work in this field and is from New Hampshire and does, I love seeing all the work that they're doing there. And it really just goes to show how one story can have such an impact. Although we would really love to see a movement to more prevention instead of reaction so we can keep mothers here with us. So I will hand it over to Heather.
Hi, everyone. So my name's Heather Martin. I had lost my sister tragically 16 years ago to maternal suicide. Is there a next slide? Oh, every time. So this picture inspires me every time I see it, and it mixture of emotions every time. This was at the butterfly place. There's a place with butterflies, and she absolutely loved these blue morpho butterflies, and one flew right on her back, and it was just the perfect picture and just shows her beauty even more. But yeah, 16 years ago, my sister was pregnant with my beautiful niece. It was the first grandchild for both her and her husband, their family, and just so excited, had a great pregnancy and great childbirth experience. She was very spiritual, into yoga. She was actually a yoga teacher and taught yoga to children. So just a very spiritual, earthy, amazing woman. And she gave birth and she did hypno breathing. She told me she didn't feel a thing. I still don't believe her. So happy. And she went home a couple days after giving birth to her daughter. And within a week, something just changed. The look on her face was nothing that I had ever seen before, and I never want to see on another woman's face. It was just a lost stare. Just there was nothing, there was no light in her eyes, and it's very hard to describe. And like I said, I never want to see it on another mom's face. And she had asked for help. She had told her husband, just, I don't feel right. She wasn't wanting to hold her baby. I think she honestly was scared um, that she was either going to harm her baby or she just wasn't connecting with the baby. And I can't imagine the shame that she felt because she was so excited for this baby. And so she had said that she had some suicidal ideation. So she had to go to the emergency room, which was the only place for her to go because of her suicidal ideations. And she had been admitted without her baby. She was very, very adamant about breastfeeding. She wanted to be, natural, no formula. So not being able to breastfeed her own baby and having her baby right there with her was, I think, just made it all the much worse for her. And just wasn't sleeping. That was a huge sign. She just wasn't sleeping. So I think all of that in combination, we had a history of bipolar in our family. My mother was diagnosed with bipolar. My grandmother, hearing stories after the fact, after we had lost her, just really put the pieces of the puzzle together. And um, she had wanted to go home because she was away from her baby. So she was discharged within 2 days, put on medication, went home a little bit better, but I just knew something. She just wasn't 100%. And everybody was just around her constantly. So thinking that she needed a break, from everybody just being there on top of her at all times and letting her get rest. Um, she was left alone for a couple hours while my brother-in-law had taken Elena to his brother's surprise birthday party because she had all of us fooled. She had told us, she just needed to rest and she's okay. And I had even called her that same morning. Um, I wanted to go over there and be with her, and she just said, I just need to rest. I'm okay. And within a few hours, she had taken her life. And just, I'll never forget the phone call from my mother, just screaming, and I knew that she was gone. I'd never heard my mom cry or scream like that. So it's been really hard to figure out all the things that went wrong. And, there were people that truly tried to help her, but as we know with postpartum psychosis, there's what we call waxing and waning. And I know you guys will explain a little bit more about that, but I really, she had everyone fooled. We thought she was doing better. And looking back now, there was some things that we could have done differently. And seeing what my part is 16 years later, I really have put so much effort and energy into advocacy because I never want to see this happen to another mom. It doesn't matter where you're from and, how much money you have, how much support you have. This can affect anyone. And that's the message that I'm hoping to portray to others is always look out for mom and ask if mom is okay. I truly love that slogan because we don't ask it enough. We're always, looking at the baby but it's like, how is mom doing? So Thank you for letting me share my story today. It's so important to have these webinars and to share all the information that we know to prevent another tragic outcome. Thank you.
Thank you so much, Heather. Thank you for sharing and thank you for all that you do. I've seen all the work that you do and it's incredible. And I'm sure it doesn't get any easier to continue to share and the trauma and the heartache that that brings. So I really appreciate um, you sharing your sister with us today. And I hope, we are here to ultimately save lives and prevent maternal suicide. One mom lost is too many, and this is one story you've heard today, but I truly believe that we can change the trajectory in maternal mental health and move forward to prevention and seeing no mom die to this. So thank you so much for sharing, Heather. Next slide, please, Amanda. So we're gonna get started. Actually, let me back up a little bit because me and Allison will both be sharing some things today. She's gonna be sharing a bulk of the information, but Allison Palmer is here with us. Hopefully you can see her face. Sometimes I get confused of what people can see on a webinar, but she is here. And I am so grateful to her. Her and Heather actually live in the same area in New Hampshire and are doing just great work up there. So Allison Palmer is a advanced practice registered nurse and a nurse practitioner. Uh, she has almost 30 years of experience in nursing as a bedside labor and delivery nurse, perinatal clinical nurse specialist, and dual certified nurse practitioner in OBGYN and reproductive mental health. That is just a very short snapshot of all the amazing things that she has done and all the experience that she has. But she will share in just a minute. I am going to go over the key facts and hidden realities of maternal suicide. You may or may not be aware, but it is a leading cause of death in the postpartum period. And that to me is just unacceptable. The CDC just started tracking maternal suicides in 2018. And I actually do remember some of the conversations we had before that and that changing very shortly after. So it's amazing how advocacy and speaking up can lead to change. The first year after childbirth is one of the most vulnerable periods for a birthing person's mental health. Um, and risk of suicide is highest in the first 6 to 12 months postpartum, especially without adequate mental health care. But with early identification, access to quality mental health care, and community support, it is largely preventable. So those are some of the key facts that we're going to be talking about today and how we can move towards prevention. Next slide, please. And this just kind of shows you the trajectory and where these suicides are happening. And it's largely in the first year postpartum, like I said, after that 4-month mark, with 62% occurring during that time. Next slide, please. So just some of the misconceptions about maternal suicide is that, um, it occurs, there's so many misconceptions. Um, they, especially in the South, I'm in Tennessee, I'm from North Carolina. We tell moms to, get tough, get through it, pull ourselves up by the bootstraps. And that's just not how it is. And society puts so much pressure on moms, and we're just supposed to be happy. But sometimes that's just not the case. There's one picture I don't have in here, but it's me with my toddler on top of my arms, this big smile on my face. And just days after that, I was in the psychiatric unit battling for my mind and my life. So moms aren't always happy. They can't always tough it out. And not everybody has strong support systems or people around them that understand the difficult thoughts that moms may be having that can be really, really scary to them. And so it's important for as many people that we can to be aware of these realities so we can ask the hard questions, sit in the hard, difficult moments with new families, and just be there and listen. Next slide. And I think this is where I will turn it over to Allison.
Okay, thank you, Christina. And Heather. Heather's my partner in crime with the New Hampshire Mom Hub and a lot of the legislative work that we're doing in New Hampshire around maternal mental health. She and I are also connected unfortunately, through the tragic loss of her sister 16 years ago. And so we have been, this is a passion. It's what we do every day. So, moms should not be dying. And I think, like Christina was saying, a lot of times we create norms within our culture, within our communities, that having a baby is meant to be this joyous, exciting, wonderful time. And so if we're not also normalizing the fact that things can also be hard and challenging, we're doing a major disservice to mothers. So some of the warning signs and risk factors that one of the biggest things, two of the biggest items are if somebody has a personal or family history of a psychiatric disorder, or they have a prior suicide attempt or suicidal ideation. Those are two of the bigger warning signs and risk factors that as clinicians, we can be asking those questions about family history and really then tying it to what that really means and how to educate patients and families about what to be looking out for as they navigate pregnancy and those early weeks and months after birth. If you're hearing things from a mother, like expressions of hopelessness, they'd be better off without me. You're seeing more social withdrawal, agitation, sleep disturbances, like they can't sleep when they're given the opportunity to. They're maybe drinking more or using substances more to try to get to sleep or to help to combat that agitation and anxiety that they're having. So moms may look fine and they can be hiding their risks. Signs can be minimized and masked. And especially some of the higher risk mental health conditions is if somebody has a history of bipolar disorder, substance use disorder, or if they're in a relationship where there's intimate partner violence. So that lack of social support, also having an unplanned pregnancy, these are all additional risk factors. And I'm sure if you're thinking about friends, family, or patients that you work with, you might be seeing how these items can add up. They often don't occur alone in a silo. So when you see multiple risk factors coming together, that can again really drive home the need to talk about this. 34% of pregnancy-related suicides involved a prior suicide attempt. So again, really looking at what their prior history has been. Let's see, also being a young age, if there's family conflict, other family losses that have occurred. Next slide. Also, maternal suicide is not all equal. We have, postpartum suicide is the leading cause of maternal death. It affects women from all cultural backgrounds. Asian women are 9 times more likely than white women to experience suicidal thoughts in the immediate postpartum period. Black and Latina women are almost twice as likely than white women to have thoughts about suicide during this time. And the reason I correlate this back to white birthing people is that a lot of the research has been done around white birthing populations. We also see in India, the suicide death rate among women, especially postpartum, is 11.1 per 100,000, which is more than double the global average. Next slide. So common red flags that you might hear. So what this might look like. Hopelessness, feelings of being a burden, they'd be better off without me, is one of the strongest predictors of suicide. So we should always be asking more questions beyond this, not kind of placating oh, that's not true, and just trying to brush it off because maybe we're not comfortable with hearing that from our loved one or from the patient that we're with. If they're, again, becoming more withdrawn, having agitation, like they can't sit still, they're just feeling, having just a lot of disorganized thinking, acting in like ways that they normally don't behave. If they haven't slept in several days, like consecutively, that can be a risk factor for mania and hypomania, which can be a precursor to postpartum psychosis. And a lot of women will appear well within their visits, even when they are at high risk. So, trusting your gut and when something does feel off. With postpartum psychosis, especially again, if somebody has a history of bipolar disorder, this can escalate very rapidly. It is a psychiatric emergency. It has a higher risk for suicide and infanticide. Substance use disorders adds another layer of complexity where that can be a coping strategy and it could be a separate risk factor. It can also increase psychosis depending on the agent of substance that they're using. Also, a lot of times within the system, we do see that patients do have a lot of touch points with healthcare providers. So there's a lot of opportunity for screening. So that really underscores the need to do universal screening, asking these questions at every visit. And then having a plan to do something with those results. Some of the protective factors can be, what does their support system look like? Is there family, friends, peers, clinicians? Are there follow-up phone calls, follow-up home visits that are implemented into these screening processes? Are they able to engage with other helpers in the community? I'd also like to point out, I know like our veteran and military families are at a higher risk of like 1 in 3 of an incidence of perinatal mental health conditions. And there are a lot of resources that are specific for veterans and military individuals, especially around the pregnancy and postpartum timeframe. So really trying to look at this balance as like risk factors weighing one side down, protective factors are weighing the other side down, and looking at ways that we can reduce risk by screening, treating, restricting the access to lethal means. So asking if they're having some of these thoughts, ask like, do you have, firearms? Do you have guns in the home? And then making a safety plan around that and strengthening the buffers, the protective factors like social support, purpose, treatment connection, and frequent follow-up. Next slide, please. So if somebody does endorse suicidal thoughts, and this is more in the clinical setting, like we do want to assess their level of risk. The Columbia Suicide Screener evaluates for suicidal thoughts. It's endorsed by the CDC, the WHO, FDA, and it needs to be paired with a process and a workflow for your practice to include training. Again, on this slide, you'll see Zero Suicide has a lot of great training tools. They have webinars and education around counseling on access to lethal means. I know that that's something that I have encouraged, like I'm also part of our New Hampshire Maternal Mortality Review Committee. So if there have been losses that have involved firearms, this is a resource that, sometimes we'll look at, may be helpful to amplify. Let's see, and next slide. Just going over a little bit, two other types of screening tools. The ASQ or Ask Suicide Screening Questions toolkit is very, very straightforward. It takes like 20 seconds to ask these questions. It has a lot of different links within this toolkit on language and for providers and just for people to ask how to ask questions around suicide. And the other tool that I really like is the CAMS Care, which is the collaborative assessment and management of suicidality. And that is a more intensive psychological treatment that is suicide specific. It helps patients really develop other means of coping and problem solving to replace or eliminate thoughts of suicide as a coping strategy. So it's designed for outpatient settings, and it's really meant to help to keep people, out of the emergency room. As Heather noted, a big risk is that, people sometimes get admitted to an emergency room and then an inpatient psychiatric unit. And during the perinatal period, this in some ways can sometimes do more harm than good. While it's a safe, place perhaps for the patient to be, it's not, these units are very generalized and not specialized to the perinatal needs of mothers. So they can often feel like they're not getting what they need. And so then they may want to discharge prematurely. So really being able to connect, assess using validated screening tools, manage, like learning how to create a safety plan, referrals, and follow-up, listening without judgment, normalizing therapy, medication, peer support. And if there's imminent risk, obviously we don't want to leave mom alone. And I think there's a lot of proactive things that we can do. And I think like what Heather was also noting is that it can be tricky. It's not always easy because sometimes if we're also hovering over mom, she may also feel like she needs space. So I think sometimes early on having those conversations that you can talk about proactive planning can be helpful. Next slide. And so we're going to talk about what we can do for support. So the first part in like a safety plan is, recognize warning signs, finding internal coping strategies. What are things that people can do alone, as far as relaxation, exercise, grounding, mindfulness. There's a lot of apps and things that people can do independently. Distraction through people and places, identifying safe environments or social settings that might provide relief. Finding their supportive people to call. For instance, if they use substances, like who are their sober supports? They should have a list of people that they can call. That's part of that safety plan, that they know that they can trust. Having a list of your professional contacts, like if you had a major, maybe you have epilepsy and you have your neurologist on speed dial. Same thing for your mental health providers. And I encourage people to really do a lot of proactive planning early on throughout the pregnancy, and ideally even prior to pregnancy, if possible, if you have a pre-existing mental health condition that needs to be assessed. Ensuring a safe environment with a crisis support plan. I think we can go on to the next slide too. Helping a mom that might have suicidal thoughts. If they have a screening tool that's positive, or they're sharing things with you, try to bring them to a private, quiet environment that you can talk to them more directly. Say what you see. I'm worried about you. Are you thinking about suicide? Validate. Thank you for telling me. I know this is a hard conversation, but I'm here. I'm here for whatever hard things that you need to share. Talked about, like, obviously if things are more imminent and she needs to have support right away, calling 988 or 911. Some communities have community mobile crisis teams that can be deployed to your house or to the office, wherever the setting is. Working on making a simple safety plan together, like looking at like warning signs. I often call these like red flag symptoms in patients, like what are your red flag signs that you're not doing so well? Thoughts, feelings, I get withdrawn, I don't talk to people anymore. And what are some coping strategies, things and people you can call. And then after, keep showing up. I think the big thing is like having daily check-ins, whether it's with a friend, a family member, if with clinical follow-ups, making sure that you're having like you have them connected to a higher level of care with professional help, that they are getting, assessed for at emergency services for mental health issues, and that they have like a follow-up plan in place, and also engaging their support system or anyone at home or lives near them. Try not to minimize, saying, oh, other people have it worse, or, oh, you'll feel better. You just need some sleep. You'll feel better soon. Like all moms feel this way, and don't promise that you're going to hold this in confidence or secrecy if mom is at risk. I always say, don't worry alone, bring others to the party, get other people involved, and try to make a plan and rally around mom. That's really what we need to be normalizing in our communities. Next slide. Along the lines of postpartum planning, like Postpartum Support International has a class that is offered twice a month. They also have like a PDF little packet that has like your postpartum plan. So it has like great questions to ask for anybody to think through, that I think is like really good, like protective, like planning for our mental and emotional health postpartum. So while we're planning for like a baby shower and a gender reveal, perhaps, and like all the fun things, like this should be like a really integral part of how we help to raise our moms. Next slide. Postpartum Support International has an app that you can connect to a warm line where you can get in touch with volunteers that will get you connected to your state coordinators. There are state coordinators that can also be the boots on the ground to help connect you to a therapist, a support group, other resources right within your community of your state. There is the 1-833 TLC Mama, which is the National Maternal Mental Health Hotline. That is 24/7. That number and 988 can both be used at any time to call, chat. So if a mom's struggling in the middle of the night, any time this can be accessed. And then PSI also has over 50 free online support groups. So in a lot of different specialized areas. Next slide. In terms of like prescribing medications in pregnancy, there's again, this kind of goes into the same thoughts along with like the misconceptions. Sometimes people are, ourselves, we might think, oh, well, I'm pregnant, I have to stop all my medications. Or you might actually have a provider who doesn't have a lot of training around treating mental health conditions in pregnancy or postpartum. So because of that broad competency, there's a big need in order to avoid moms bouncing around from one provider to the next. We really need to educate and empower all of these points of contact, whether it's like pediatricians, family practice, OB, the emergency room, psychiatry, and get them knowledgeable with points of contact for evidence-based guidance and resources. One of those is Mass General, Center for Women's Mental Health. They have a blog that is wonderful. They have a new podcast. And all of the, they have a lot of different levels of reach, I feel like, to reach clinicians and like the public as far as updates in maternal mental health and medications to treat these conditions. They also have a perinatal psychosis project consult line for providers. So that's only for clinicians, but you can consult about a case that you have concerns about. For the public too, I think Mother to Baby is a wonderful resource. They have fact sheets that are written in very plain language around different exposures to medications, illnesses, and as well as LactRx, which is an app, as well as Infant Risk, which is Thomas Hale's breastfeeding and mother's milk lactation resource. Repro Talks is also another app or web platform that requires a subscription, but has reproductive psychiatry guidance from preconception through breastfeeding. Next slide. Oh, and also I'll just mention the PSI also has the perinatal psychiatry consult line. So that is also just for medical providers. So that's another resource that if you don't have, say, a perinatal psychiatry access line within your state, this is something that you can submit a form to PSI, and they have reproductive psychiatric professionals that will consult with you and help you process treatment options for your patient. So next slide. So I just wanted to end with the National Maternal Mental Health Hotline that we have here that's 24/7. The Postpartum Support International Helpline is meant more so for individuals who are not in crisis, but that if they need resources and referrals for maternal mental health conditions, and you can get connected to your state coordinator. And then we always have 988, the 988lifeline.org for emergencies. So I'll end there and just wanted to open up for any questions.
Thank you so much, Allison. I told you all it was going to be a jam-packed session of great information. So if you have any questions in the chat, I know we're past time, but that's okay. We'll stay for a few minutes and answer any questions. And it'll also give us a good idea for any future webinars as well. So don't be afraid to put your questions in there. And we'll go ahead to the next slide. Of course, this is brought to you by Cherished Mom. We are honored to do this work and really grateful for all of the people that have joined us today. And if you'd like to donate, you can go to that QR code there. And I think we have a question. From Dr. Julian. Let me see how I can do this. I'm going to let you talk here. Okay, there we go. Maybe that didn't work.
I think she's muted.
I think so. Dr. Julian, can you unmute yourself? And I think I let you talk. If that doesn't work, I'll just bring you on as a panelist. However we can make it happen. All right. If you had a question, Dr. Julian, just raise your hand again. Maybe you didn't accidentally hit that. And we went back to this slide because someone asked to go back to that slide. And again, if you have any questions, put them in the chat, or you can feel free to email us at info@cherishedmom.org, and we can get any of those questions answered for you.
Yeah, I think some of these resources are really important to remember when we have, I have a lot of providers that sometimes will be like, well, there's nowhere to send anybody. And I think that sometimes is a really broad blanket statement. Yes, we do have limitations for sure in like where and who and timeframes and wait lists of where we can send people. And there's a lot of resources that we can pull from to get some information, and especially with I would say that the PSI perinatal psychiatry consult line and the postpartum psychosis project at Mass General. Those are two peer-to-peer resources that I think are really excellent. Mass General also has a grand rounds every Wednesday at 2 p.m., which is a great place for people to bring cases and questions. And you'll talk with Dr. Marlene Freeman and Dr. Lee Cohen, who are experts in the field.
Thank you for that. It is really great if you're able to attend those grand rounds. I've attended them a few times. Really great information there. And so the National Maternal Mental Health Hotline is one of the, if you don't remember any other resource, definitely remember that one. It is the best resource you can give to a struggling family or mom. And, you know, sometimes folks are scared to call that or reach out to them by themselves. So one option is you can always, hey, let's call this together just to see what it's like. And they can text too. I used to work on the hotline. Surprisingly, I thought that we would get a lot of text messages in the middle of the night. But more people actually called and talked, which was really, really neat to see. So, all right. If there's not any other questions, we are going to let you all go and wrap up. Feel free to reach out to us through our email, and we can direct any information or provide any other information that you're needing. And we're so glad that you all attended with us today, and stay tuned for any upcoming events. And again, thank you. And thank you, Allison, for being here and sharing all that great information. And thank you, Heather, for sharing your story.
Thank you for having us.
Thank you.
Honor to be here.
Yeah.
Thanks.
Yes.
All right. Bye, everybody.
Bye.